Start now.
Yes, ma'am. I'm Jivita. I'm going to present a case of prolonged pregnancy. A 22-year-old Mrs. Shanti from Ainavaram, housewife belonging to socioeconomic class 3, who is primary gravida. She was booked and immunized at KMCH with LMP on 4/11/4/1/2020 and EDD 11/10/2020. Her current gestational age is 40 weeks plus 5 days. She presented to the hospital with a complaint that a due date of delivery had already passed. Presenting complaint, she is a primary gravida who crossed her EDD by 5 days. She conceived spontaneously and her pregnancy was confirmed by urine pregnancy test at 2 months of amenorrhea at KMCH. She was sure of her LMP, which is 4/1/2020, and a regular menstrual cycle of 28 days. Her ultrasound taken was corresponding to her gestational age. She was able to perceive fetal movements, but she had no history of any true labor pains. Present obstetric history, no history of preconceptional counseling. Conception occurred spontaneously 5 months after marriage. Pregnancy was confirmed by UPT at 2 months of amenorrhea at KMCH.
Okay, so let me stop you here 1 minute. So because you're stressed 2 times that you've done UPT at 2 months of amenorrhea. So when will a urine pregnancy test be positive, or ideal time to do a urine pregnancy test?
35 days of amenorrhea.
Yes, so it is almost till 5 weeks. Okay, so if your patient has done a urine pregnancy test at 5 weeks and you're going to stress on that, then it makes sense. It means the dating is correct. Okay, because a urine pregnancy test is supposed to be positive at 5 weeks and your patient has had a positive test at 5 weeks. Okay, so now stressing and telling that the patient had a urine pregnancy test positive at around, like say around 2 months, which is almost like 60 days. Okay, so which doesn't make much of any significance here. Okay, so that is how most of the patients do. See, there are only a few patients who exactly come at 5 or 6 weeks and do the test and scan and all those things. Okay, so I mean, if it is not like that, I don't think you should stress too much on that. Okay, go ahead. Yeah, proceed, doctor.
Next slide. First trimester, history of nausea and vomiting till 3 months, no history of hyperemesis gravidorum, no history of fever with rash, no history of bleeding per vagina, no history of burning maturation, no history of vaginal discharge, no history of irradiation, folic acid tablet were taken, dating scan was done, and NT scan was done. Second trimester, quickening felt.
Okay, so this is incomplete when you don't say at what weeks your dating scan is done and what weeks your NT was done. Okay, so okay, let us have some brief little discussion about what is early trimester scan and when it has to be done. Okay, so what is the ideal time to do a dating scan?
9 weeks.
Yes, from 9 weeks you can always do a dating scan. Until what weeks you can get the proper dating scan done? You can start at 9 weeks. I completely agree. Okay, till what weeks? Sometimes even 8 weeks we accept. So from 8 weeks to
11 weeks, ma'am.
Yeah, no. Ideally, you can do it up to 14 weeks. Okay. When does the NT scan be done? When can you do an NT scan?
11 to 13 weeks, ma'am.
Yes, 11 to 13 plus 6. It means you cannot do it after 14 weeks. Okay. Some people, ideally, it should be done in less than 13 weeks itself. Okay. But you can still do it for 13 plus 6. That's a little gray zone here, whether we can do it in this week or not. Most of the people, whoever does that, we always prefer to do it at 12 plus weeks. Okay. When it is 11 weeks, the baby will be very small. So to see all the details in the baby will be very difficult. Okay. So that is the reason we wait for at least 12 cross weeks so the baby is a little bigger and we can pick up the other gross anomalies there. Okay. So now with these two information, if I tell you there is one particular time you can do a dating, you tell me when will you do that? Your patient, see, your patient is a government hospital patient. Okay. So he is not very affordable. So you cannot say, okay, I will do one at 6 to see a scan, then I ask her to come at 9, then I ask her to come at 12. See, these are all the luxury which the patient who get it in the private hospital. Okay.
Yes, ma'am.
Not the poor research setting or any government hospital patient. So if you go to an exam for government hospital, or if you're there already there, then you cannot tell all these things. Okay. So with this idea, you tell me only one scan your patient can do in the first trimester. So when will you want to do that scan?
Before 12 weeks, ma'am.
Around 12 weeks. Okay. So around 11 to 12 weeks, you can just do one single scan. So that will give you information about dating. Okay. What is the importance of your 11 to 14 week scan? Kindly mute the videos, someone. Okay. So fine. So 11 to 12 week scan, dating you do. Okay. What else can you do there? What is the importance of 11 to 14 week scan?
Crown rump length can be measured, ma'am.
See, we measure crown rump length, okay, from 6 to 14 weeks. Okay. So it doesn't make much of a difference. See, that is what the measurement is there. So that is the only measurement taken for you to say the fetus size. So that is okay. So what is the extra thing we see between 11 to 14? You told NT scan. What does NT mean? What does NT mean? Yes. What is that? What is nuchal translucency?
For Down syndrome.
Very good. But what is that? What is nuchal translucency? What does nuchal mean? Okay. See, but you should know, okay? You are expected to know nuchal translucency, okay? So this is a fetus. We always see my diagrams a little, it doesn't look so beautiful. So whatever. So this is the head of the baby, okay? Then you have the nose, the nasal bone, and then you have the maxillary view also. This will be the face, and in between, and then it will be the chest wall, okay? So this is the fetus, and here somewhere your umbilical cord will join, and the hand somewhere it will be here, and then it will be the legs. Okay, so let us imagine this is the mid-sagittal view of the fetus. It means exactly you cut the fetus into two halves in the sagittal plane. This is the plane where you're supposed to measure your NT. Okay, so you should see the nasal bone clearly along with this maxillary area and the mandible. So it will be these three lines will be seen in a scan. Okay, I'll get the pictures next time. Sorry, I didn't have any pictures this time. And then you'll have your heart and other things. And this is the neck. Okay, below the neck, you will see a translucency. Okay, it is nothing but a transparent area which will be seen in this area. Okay, the neck of the baby. So, and behind that, you will have the amnion or the chorionic membrane which will be there. So this will also be here. Okay, so this is the chorionic membrane which is covering the whole baby here. So this will also be there. So you should, in NT, we measure the exact length behind the neck. So this is the neck. In between, like after the cross the jaw, this measurement we measure. So from the topmost area to this, we measure the maximum length which is there, and that is the NT. Okay, so at least you should know the fetus is taken, and this is the same view where you're going to take crown rump length. So crown means head, rump means the buttock, that is your sacral bone, the edge where it is going to be there, the lowermost part of the baby will be the rump. So when you measure this length, this is the crown rump length, which is your CRL. So even if it is 8 weeks fetus, which is like this small fetus, so again you put a measurement in your head, the most prominent part in the lower pole is rump, and then you measure this, it is a CRL. Okay, so it doesn't mean you measure the CRL only during NT scan. All early scans, it is going to be CRL only. Okay, till 14 weeks, your baby's measurement is only crown rump length. So don't get confused with that. So in NT, so you should know what is NT. NT is nuchal translucency. Nuchal means neck. Okay, so the translucent area which is seen behind the neck area is what we measure, And if it is elevated, usually we take a cutoff of 6 mm, which is very high, and 3 mm itself will give you an saying that there is a suspicion of Down syndrome. Okay,
Down
so
syndrome.
so that is what you have to remember. um, and another thing, like, usually usually there can be some accumulation of fluid or water or lymphatic tissues behind the neck, so that is why your NT is going to be high. Okay, so what is the condition where your lymphatic dilatation is seen behind the neck? Anyone?
Cystic hygroma.
Excellent, doctor. Excellent. I'm very, very impressed. So in cystic hygroma, imagine instead of the green line, you will have this kind of a picture between the neck and, I mean, like, you'll have too much of fluid accumulation. It can be lymphatic fluid. So this will be the accumulation here. Next class, I will get the pictures for you. So if it is going to be there, then you know that it is anomalous fetus or a, like not a very good fetus, and it is an increased NT. Okay, so you should sorry, your slides have gone. Is it for me or is it for everybody? Sorry.
One minute more.
Yeah, no problem, doctor, take your time.
Ma'am, I have one doubt, ma'am.
Yes.
What is the dose of preconceptional folic acid dosage, ma'am?
See, ideally, okay, even point, I mean, like 400 micrograms, it's, I mean, 500 micrograms is what is available. Not 400 is not actually available. So even 400 micrograms of a dose of folic acid is good enough, okay? But it depends on which condition you're giving. For example, if you're giving a patient who is epileptic, okay, so there the risk of neural tube defect is more. Or if a patient is already a diabetic, okay, so in all these high risk women, the dose is 5 milligrams. Okay, so for a low risk women, even if you give 500 micrograms or 0.5 milligrams is good enough. Okay, but for a high risk woman, it will be 5 milligrams. Most of the commercial available folic acid will be either 5 milligram or it will be 1 milligram. So most of us, we go with 5, but ideally you need not have so much high dose of folic acid. Okay, so we were with NT. Let us complete the NT if you fine. So NT is that increased length. Okay, what else do you know that they see in the NT scan? What all can be given? What are all the anomalies that can be picked in an NT scan? You know what is the size of the baby when we do the NT scan? Anyone has read the size? So between 11 to 14 weeks, which is 45 to 84 centimeters. I mean 84 millimeters. It means your baby's maximum size is going to be 4 centimeter at 11 weeks and 8 centimeter at 14 weeks. So the baby is going to be very small. Okay, it is just 4 centimeter size small baby. So you cannot imagine to pick up all the anomalies here, but there are certain gross anomalies which can be picked up. So anything you know, what are all the anomalies which can be picked up in the first trimester? One is cystic hygroma, which you already got it. What else?
Anencephaly, ma'am.
Excellent. So usually by 11 weeks we get head is formed. Okay, so in this NT where you have the head size and the CRL and you have all your nasal bone and this and the neck and the chest, so this is how the baby is going to look. Okay, so if this portion of the head is not there, so you have the face, you have the body, and you have a batch like that, and then this is anencephaly. You don't have the skull bone which is developed here, and the brain will be exposed. So anencephaly can be easily picked up by around 10 to 11 weeks. Okay, earlier it should be picked up. What else? What other anomalies can be picked up? One is megacystitis, which is the increased size of the urinary bladder. So when the baby is lying there, when you have a big bladder occupying that, then you can pick it up. Okay. And the other anomalies which can be picked up is your omphalocele or gastroschisis is difficult. So omphalocele you can definitely pick up. So here, and you will have all the bowel and other things which will be herniating. So definitely by your 11 or at least 14 week scan, you'll be picking up your omphalocele. Okay. A patient comes with you and she says a 9-week scan reporting omphalocele. What will you do?
It is a physiological condition, so
Excellent,
it can
doctor.
go back.
Excellent. I am very, very impressed. By 9 weeks, okay, omphalocele is physiological. Okay, so the bubble happily goes here, then it comes back. Okay, so this is a physiological omphalocele. So if anyone has as reported a 9-week scan showing omphalocele, you have to remember it is physiological. So physiological in the sense you should not go and terminate the baby because this is normal. Okay, why you should know all these things as undergraduates? You can be in any department, any field. There will be people who will bring the reports and ask you doubts. So at least these basic things you should understand, which is normal, which is not. Okay, so omphalocele at 9 weeks is physiological, but the same thing if it is still persisting by around 11-12 weeks, then you know that is anomaly. Okay, other than that, what else we do is we see the ductus venosus flow and the tricuspid regurgitation in NT scan. And all these things will also give us towards Down syndrome. So these are the, in case if you are like answering extremely well, then these questions may come. What else can be seen in NT scan? Otherwise, usually they don't, you are not scrutinized if you don't know this. Okay. So you should know what is NT, what is the plane which we measure NT, what is normal value, what is abnormal, and if it is abnormal, what you should suspect. And along with that, the other markers which are seen is ductus venosus flow and tricuspid. If you can remember, at least you know that 11 to 14 weeks scan. It's very important. Along with that, we do a blood test. So what is the blood test which we do for along with NT scan? Downs marker. Come on, this you should know.
PAP and something.
What is the test called? Yes, it is called as double marker. So
Yeah, yes,
double
double
marker
marker
means there are 2 tests. One is PAP A. Okay. Pregnancy associated placental protein A. That is PAP A. The other one is beta HCG or HCG, whatever you call it, serum HCG level. Okay. These will also give you towards Down syndrome. Okay. And do you know the importance of PAP-A apart from Down syndrome? Importance of PAP-A?
IUGR.
Excellent, doctor. Preeclampsia and IUGR. I'm very impressed with this batch. Okay. Because PAP-A has been found a low PAP-A. Okay. When the PAP-A values are less than 0.4 moms, multiples of median. And next time I'll bring the images. Very sorry, I'm not ready with anything, but next time I will at least show you how a Downs report will be there and where you should look and what you should see. So I will get it for you next time, but at least you should know a low PAP-A of 0.4 moms, then it is suggestive of placental insufficiency possibility. Okay, so it means the patient can have IUGR or can have preeclampsia. So that is one of the importance of PAP-A and your beta HCG. And these two are the marker for Down syndrome. Okay, your HCG will be increased and PAP-A will be low in a Down syndrome baby. Okay, so fine, continue with the class. Sorry to interrupt. Hopefully you didn't get diverted.
Second trimester, quickening fell to 20 weeks. Iron and folic acid tablets were taken regularly. TD injection 2 doses were given 4 weeks apart. No history of bleeding PV, no history of pedal edema, no history of fever, no history of gestational diabetes mellitus and gestational hypertension. OGCT was done and found to be normal. Anomaly scan was done and found to be normal.
Okay.
Third trimester, she was able to perceive fetal movements and adequate weight gain attained for gestational age. No history of fever, no history of pedal edema, no history of bleeding PV, no history of gestational diabetes mellitus, no history of PIH. Growth scan was done and found to be normal.
Okay.
Past medical history, no history of diabetes mellitus, hypertension, asthma, epilepsy, thyrotoxicosis, recurrent respiratory infections and heart disease, no history of previous surgeries, no history of any drug taken for any chronic illness, no history of any drug allergy. Menstrual history, age at menarche 13 years, regular cycle once in 28 days, which is lasting for 3 to 5 days, with normal flow and no history of passing clots and no history of dysmenorrhea.
Okay, so with the, I mean, like, let us say, how many, like, in a menstrual history, how many cycles of regularity is important before conception? If your
3
patient
cycles,
says, excellent. So if your patient, she says, I had irregular cycles previously, and now I have regular cycles. So in order to call her regular cycles and whether the dating is reliable, you should at least have 3 cycles which has been regular. Okay, regular need not be exactly 28 days. So up to how many days do we call it regular? Up to
45 days, ma'am.
No, that is too much.
30,
Okay, 35 days. Anything crossing 35 days, we term them as irregular. Okay, 45 days is only for adolescents. Okay, because we give some more time for the adolescent HPO axis to mature. So for them, we give it as 45 days, we call it irregular. But for the normal adult women, we keep it as 35. Okay. So go ahead. So we are like regular cycles. Fine. Go ahead.
Marital history, age at marriage 21 years, duration of marriage 1 year, non-consanguineous marriage, no contraceptives were taken.
Okay. So why is history of contraception important?
Ma'am, it may irregular periods may happen, ma'am. Like before 2 months of usage before conception. So it will,
okay. Which contraceptive will cause irregular periods? Irregularities in the cycles.
OC pills, ma'am.
OC pills will cause irregularities. Mostly your progesterone pills. Okay. Your I will not agree with IUCD because IUCD will not do anything with the cycle. There is no relationship with the cycle. Okay. But progesterones definitely can cause irregularities, can cause intermenstrual bleeds. So if she's taken some depomedroxyprogesterone acetate 1 injection, okay. So definitely there can be a period of amenorrhea there, or there can be some irregularities. Okay, so the more important contraceptive history which we are looking into is some progesterone intake. Usually your OC pills, there can be after sudden stoppage of OC pills, you can have a rebound FSH release and it can cause multiple pregnancy. So that is the only thing for OC pills. Usually we give OC pills to make the cycles regular. Okay, so whenever your patient is having a PCOD, you give OC pills as a treatment because your oral contraceptive pills are help to regularization of cycle. So definitely it will not cause these problems. Okay, chalo, next slide.
Personal history, consumes mixed diet, normal bowel and bladder habits, normal adequate sleep pattern of 8 hours at night and 2 hours at daytime, not an alcoholic or smoker. Family history, no history of prolonged pregnancy in the mother.
Why is this important?
Ma'am, placental sulfatase deficiency may be hereditary, ma'am.
Okay, so there is a genetic component in prolonged pregnancy, so it is good that you've taken that. It's very nice. Yes.
General examination, patient was conscious, oriented, moderately built and nourished, no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. Anthropometry, height 155 centimeter, pre-pregnancy weight is 56 kg, pre-pregnancy BMI is 23.3, present weight is 66 kg, and weight gain during pregnancy is 10 kg. Vitals, afebrile, BP 120 by 80 mmHg taken at upper right arm in relaxed sitting position, respiratory rate 22 per minute, pulse rate 92 beats per minute, regular rhythm, normal in character, normal volume. All peripheral pulses felt equally.
Why is this important? Sides. Why should it be taken in a relaxed sitting position? Let the patient be dancing, no? Why can't we go and measure a dancing BP? Talking BP. Yes. kind of. Okay, see, usually, okay, when a patient walks into your clinic, okay, so she'll be very anxious. Okay, so when immediately after coming, you just make her like, sit or even stand and measure the BP. The BP is supposed to be high. Okay, at least by 10 or 20 millimeters of mercury. So you just allow. So how much time should she relax?
10 minutes.
ரொம்ப ஜாஸ்தி. அவ்வளவு நேரம்லாம் உட்கார முடியாதுல்ல. 3 to 5 minutes, okay, maximum. We can't spend more than that. So by the time you just relax, you just talk with the patient, you do all those things, and maybe after 5 minutes you can just take it. 10 is little quite some jasti time. You cannot give that. 92, is this pulse normal? If normal, why?
No, ma'am.
What will happen to the pulse rate in pregnancy?
Initially, it will
Increase.
It will increase by
increase.
10 beats per minute.
10 to 15.
10 to 15 beats per minute.
Beats per
So
minute.
if you normally take your patient to have 75, so if you add on with 15, so 90 beats per minute is still normal in pregnancy. Okay. So you need not think of any cardiac lesion, arrhythmias, or anemia or anything. It can still be normal in a pregnant woman. Okay. But if a patient has a pulse rate of 110, okay, that you cannot quote up to normal, because maximum you can go up to 90, 95 is still fine. But once they cross 100, 110, it is still abnormal. Okay. Chal, go ahead.
Examination of breast, soft, non-tender, no traction of nipple, skin around nipple normal. Examination of thyroid, thyroid is not enlarged. Examination of spine, no abnormality seen. Abdominal examination, after getting consent from the patient, the procedure was explained and the patient was asked to avoid urine before examination. Abdomen was exposed from xiphisternum to pubic symphysis and dorsal portion with semiflex thigh. Inspection, abdomen is longitudinally enlarged, stria gravidum present, linea nigra present, umbilicus is elevated from plane and in midline, shelving sign present, no visible pulsation seen, no scar, no engorged vein.
What is shelving sign?
Ma'am, shelving sign should come in palpation. Ma'am, it is forward falling of the uterus. So the
Will you
examiner,
see that in a patient who is lying down with semi-flexed thighs and she is literally lying down? And how can that falling forward see? Okay, see, this is an unnecessary word. It need not be present here at all. Okay, shelving sign is nothing but when your patient is sitting, okay, or maybe standing, okay, the tummy falls down. Okay, instead of standing like that, the level of tummy little bit falls down. So that is what you call it as shelving sign, right? So here your patient is lying down. So the tummy is anyway going to be like this. I don't think it is going to fall down like that when she's going to lie down. Definitely no, not during lying down. Okay, go ahead.
Palpation, ask patient to semiflex at hip and knee joint. After correcting the dextroversion, the fundal height, uterine height of 32 weeks with fullness of flank corresponds to term. Abdominal girth is 90 centimeter.
Wait. Abdominal girth varaikum measurement irukku. Where is symphysis fundal height? Very important. Correct, no? If you have an explanation, I will still agree.
Who is this?
Beyond 36 weeks, it will not correspond to the gestation age, ma'am.
Yeah, so there is not much of a, information with symphysis fundal height. Usually we don't ask after 36 weeks.
Yes,
okay, because anyway it is falling down, it is going to come back to 32 weeks. So usually many people will not be doing symphysis fundal height. Okay, I agree with you. Go ahead.
Fundal grip, soft, broad, non-independently ballotable, probably breech. Umbilical grip, smooth, curved, hard, uniform, resistant on left side.
I'll be more happy if you say buttock.
Okay, ma'am.
Okay. If you say breech, it means a different presentation. See, the examiner, some words, they just strike them. Okay. So then they'll come back and say, you told breech, no. Like that, it's always better to say buttock. Okay.
Okay. On the other side, irregular small nodules felt, suggestive of limb buds.
Okay.
First pelvic grip, hard, round, bilateral mass size 2 of head of the fetus. Second pelvic grip, findings of the first pelvic grip confirmed. Fingers are diverging, indicating that the head is engaged.
Okay.
Auscultation. Fetal heart rate heard on left side below umbilicus on the left spine umbilical line with a fetal heart rate of 140 beats per minute. For
Okay.
vaginal
So,
rectal examination not done.
okay. So fine. So this is the patient. Okay. So you have anything else? Any other slide you have?
Other systemic examination normal.
Okay. Okay.
Summary.
Fine. Summary.
Mrs. Shanti, 22-year-old, belonging to socioeconomic class 3 primary gravida, booked and immunized, whose EDD is 11/10/2020, was admitted at Gkmc with gestational age of 40 weeks 5 days, crossing her date with a regular cycle, and she conceived spontaneously and she was able to perceive good fetal movements. No significant general or systemic findings. Systemic examination findings. On obstetric examination, the uterus is term and the flanks are full. Shelving sign present, longitudinal lie, cephalic presentation, single live fetus with head engaged and fetal heart rate of 140 beats per minute.
Okay. So it is not a mobile head. Okay.
Yes, ma'am.
Fine. So let us come to start discussion. Okay. Why should the patient not cross dates? Let her cross. No, what big deal?
Ma'am, I can understand the question.
I mean, why are we worried? Oh my God. Sorry. Why are we worried if a patient is crossing the dates?
Beyond 40 weeks, the amniotic fluid will reduce, ma'am.
Why? Why? Why should amniotic fluid reduce? You're not wrong. But why? Why should amniotic fluid reduce?
Aspiration.
See, usually your placenta functions decreases nearing term.
Placenta
Okay.
insufficiency.
Okay, so what happens? So there are not going to be much nutrition transmitted through the placenta to the baby. Okay, so the baby is going to pass less urine. Okay, so that's why the amniotic fluid is decreasing. So the amniotic fluid is nothing but your baby's urine.
Urine.
So if the baby is going to pee less, then the amniotic fluid is going to drop. Okay, what else?
Okay.
In post-term, what are all the other complications?
Meconium aspiration syndrome.
Meconium aspiration syndrome. Why?
Because of cord compression, there will be fetal distress, ma'am. It will lead to
meconium. Okay, see, one is your amniotic fluid is less. Okay, so because of oligo, so sometimes there can be cord compression. Then there can be fetal hypoxia, asphyxia, and all those things. Okay, and that can also cause to meconium in the fetus to pass, and then you can have meconium aspiration syndrome. The other thing is when your baby approaches near term, okay, there will be a vagal stimulation.
Vagal stimulation.
So vagus is what? Sympathetic, parasympathetic?
Parasympathetic.
Excellent.
Parasympathetic.
So parasympathetic will cause, what will it cause with the sphincters? If you want to pass motion, is it a sympathetic act or a parasympathetic?
Parasympathetic.
Excellent. So your parasympathetic will allow the sphincters to relax. Okay. So the sphincters relaxes. So whatever meconium which is withheld will be passed into the amniotic fluid. And because the amniotic fluid is already very less, so then it cannot be diluted. So it becomes a thick meconium fluid, and that causes meconium aspiration when the baby is delivering. Okay, so one is your amniotic fluid decreasing. Second is fetal hypoxia per se can cause problems. Then what else? The baby is being inside for some more days. So it is getting more nutrition. Yes. So weight gain
Macrosomia.
can be high. So it can cause macrosomia. So once it becomes big, it cannot deliver, right?
Shoulder dystocia.
So shoulder dystocia can be there, okay?
Birth
And
trauma.
even labor dystocia can be there.
Yes, ma'am.
This big baby may not enter into the cervix, so it cannot dilate the cervix, it cannot come inside. So labor itself can go in for dystocia, and then you may not be able to deliver the baby. You may need vacuum or forceps. So the chances of instrumental delivery is
Instrumental
also
delivery is
increased. So what are all the instrument which we use?
Forceps and vacuum.
Excellent. Forceps and vacuum are the two instruments which we use.
Yes, ma'am.
Okay. So the chance of instrumental delivery is more. So maternal morbidity, fetal morbidity, everything is high. Okay. So fine. So those are all the complications which you have with the what do you call it? Post-term.
Postpartum
Okay.
pregnancy.
So let us define what is prolonged pregnancy.
The pregnancy which lasts for more than 294 days or 42 weeks from the first day
42
of
weeks.
LMP. 42
Okay.
weeks.
So anything which is lasting more than 42 weeks,
42
we call
weeks.
it as
Prolonged
post-term
or
pregnancy. Prolonged pregnancy is what we use now. The term post-term is not used. You should know what is the post-mature fetus. What is post-maturity?
Ma'am, the fetus will have long, thin body and overgrown nails. The skin will be dry, wrinkled,
Okay.
with the
So the
meconium
baby
stained.
will have a old man look. Okay.
Old man
So
look.
he'll have long nails. The baby will be thin. The baby, I mean, like, usually it will be like not the very obese ones. And it will look a worried old look. Wrinkles will be there. And why does these skin changes occur? Because
the
of,
productive loss of Verniers castes.
why does skin changes occur?
Loss
Excellent.
of protective
So you have something called as vernix, which is the protective around the baby. And as the post-term and all those things, as the dates cross, these vernix will be reduced. So that will give you the fetus typical skin changes of the post-mature fetus. Okay. So those are, those are the things you should know about post-term complications. Okay. So, now what do you want to do for this patient, your patient?
We'll
First,
wait for
this is the
41
first
weeks.
time you are seeing the patient. Okay. This is the first time. So given from the history or anything, if what are the things which is saying that yes, she's post-term? What are all the features in this patient to say that her dating is correct?
Ma'am, LMP, ma'am.
Her first history. So her cycles are regular.
Regular.
Okay. 1. Then
Quickening felt at 20 weeks, ma'am.
Those are very, very unreliable parameters, doctor.
Okay.
Those are there which
Scans,
when you
ma'am.
don't have. Excellent. So bring to scans. So she has done a dating scan
Dating scan.
as well as she's also had 2 scans in the first trimester. So one is your dating and the other one is that NT scan, and both are corresponding to the gestational age. Okay. So what else? Quickening you can still say, but like when these two are more than enough to say yes, the dating is good or the dating is correct, and yes, she is post-term. Okay. Sorry. Okay. So now let us say that the patient doesn't have all these things. So now what are all the other things which we can use? So now comes your urine pregnancy test or your serum beta HCG. But ideally, when should these things be done? Around 4 to 5 weeks. So if your patient has done something around 5 weeks, and then from that 5 weeks, if you add on these gestation age and it is corresponding, then you can still take them into consideration. Yes, it is post-term, but these are not very reliable. So quickening again, for a primary, we say 20 weeks, and then you add on with 20 weeks and you say that is the term gestation. And the one more thing which we all do is fetal Doppler to see the FHR, okay, clinically.
Yes, ma'am.
And usually, I mean, ideally, it should be seen at 10 weeks.
10 weeks.
And adding 30 weeks to this date will again give you dating. But these are all less reliable method. And the second also your anomaly scan, which is a second trimester scan. So if you don't have this is all excellent dating. When you don't have this, then you can still take these into consideration. Okay. So now what do you want to do for this patient? She is postterm, priming, 40 weeks, 5 days, no other comorbidities. What do you want to do?
Fetal surveillance will be done, ma'am, and we'll wait for 41 weeks, ma'am, before induction of labor.
Excellent. Why 41 weeks? We said postterm is up to 42.
Yes, ma'am.
What is going to happen in this 1 week?
Severe oligoironous Kannapan.
Okay, see, usually in people do a lot of studies and we follow the guidelines according to the studies. Okay, so mostly from all the previous experiences, what it is found that the perinatal mortality and morbidity, that is the baby's problems, okay, are increased after 41. Okay, so the maximum which is recommended to wait is usually around 41 weeks. And after that, the morbidity is very high. So that is why we plan delivery at 41. Okay, so till 41, how are you going to monitor this patient? So she is 40 plus 5 and you want to wait till 41. So it is just 2 days.
2 days. Fetal kick count, ma'am.
Okay.
Monitoring the fetal kick count.
How will you tell the fetal kick count? Oh, ma papa kutudan paru, ma'am.
We'll ask her to tie knots over a thread, ma'am, by assessing the movement.
How many she should try?
Cardiff's count. Less than 10 movements in 12 hours, ma'am.
Okay. So less than 10 movements in 12 hours. How else? Over 12 hours paaka mudiyuma?
Every day 2 hours, less than 10 movements, ma'am, during rest.
Yeah, that is actually, it's given in your modular. It is 10 movements in 2 hours.
2 hours.
Okay. The other routine practices, we all asked to do the movements 3 times a day, which is after each meal, breakfast, lunch, and dinner. So she can just relax, see for 1 hour after each movement. Okay. And ideally, she should at least have 3 to 4 movements in an hour minimum. Okay. So now accordingly, if you say also, it should be like 5 movements in an hour, because that is what your recent book has been giving it. So it should be at least, you can say it as 3 to 5 movements in an hour or 4 to 5 movements and every hour. And other way to say that she should actually be usually in 3rd trimester, all the patients should have the habit of writing how many movements they feel. Okay. So as compared to the previous movements, for example, if she used to feel 10 and now it is only 2, then it is definitely a significant fall in movements is there. So that is also important. Okay. The compared to the previous movements, if the movements have decreased, then it is also important. So you should know what is Cardiff count to 10. And then you should also know how else can you do the fetal movements chart. You should tell the patient how to see. Okay. So what other ways? One is fetal kick chart. Okay. What
biophysical profile, modified biophysical profile.
Okay. So one is biophysical profile and the second one is modified. So what is biophysical profile?
Ma'am, non-stress test and other
There are
findings,
5 components.
5 components, ma'am. Fetal tone, fetal breathing.
Okay, so fetal breathing movement, fetal gross body movements, fetal tone, your NST, and your AFI.
Fluid volume.
Okay, so these 5 makes your biophysical profile, and modified is the last two. If you just take these alone, then it is modified biophysical profile. So you should, I mean, like, know everything in detail about all these things, because if it is a prolonged pregnancy, your discussion is just going to be how to do fetal monitoring and how to induce the patient. So these are the two things which you have to discuss.
Okay.
So each and everything which you are going to talk is very, very important. Okay. So how many breathing movements you are expected to have?
One breathing movement for every 30 seconds, ma'am.
30 seconds, a minute.
30 minutes.
One proper movement, breathing movement, which lasts for 30 seconds
30 minutes.
in an observation period of 30 minutes. So that is what is breathing movement. அவ்வளவு சீக்கிரம் breathe பண்ணாதது actually. அதுக்கு அடுத்தது gross body movement வந்து at least எத்தனை movement?
3 body movements, ma'am.
3 body movements in the same period. அதே 30 minutes பார்க்கும்போது you should have 3 body movements. And fetal tone, how are you going to see the fetal tone? Any joint, when you see flexion extension movement, it can be in the elbow, it can be in the knee joint, it can be anything, or flexion extension movement at least you should see. So one flexion extension movement in the observation period of 30 minutes இல்லையா? So இதெல்லாமே 30 minutes உட்கார்ந்து பார்க்கணும். Nobody has time to see for 30 minutes. So that is why the modified biophysical profile has come. Because மொத்தமா வச்சுட்டு பாப்பா 30 minutes ஸ்கேன்ல வச்சுட்டு பார்க்கிறது is very, very difficult. Okay, amniotic fluid volume and NST mattume we are taking it. What is non-stress test?
Ma'am, it is the fetal heart rate acceleration in response to the fetal movement, ma'am.
Excellent. So it is your cardio tachograph which you see, and you see the accelerations in that. So we will go in detail about that. What is AFI? Which AFI we call it low? Oligohydramnias.
Ma'am, when it is less than 8 centimeter, ma'am, like overall sum of the.
According to your textbook, it is only less than 5. Okay. Usually, when it is less than 8, we keep a watch on the patient. We just carefully monitor. But ideally, less than 5 is called as oligohydramnias. Okay. And if it is a single vertical pocket, how much should be?
Less than 2, ma'am.
Excellent. So these are the numbers you have to know. Okay, so your AFI, if it is less than 5, you call it as oligoamnias. More specific is your single vertical pocket. If it is less than 2, then you call it as oligohydramnias, and then you have to decide to deliver. So these are the biophysical profile and modified biophysical profile. Clear? Anybody has any doubts? Okay, so now we should know something about CTG or NST. Why is it called NST? Non-stress test. Okay, so if you take a CTG in labor, can you call it NST?
No, ma'am. Antepartum is called NST, ma'am. During intrapartum it is called CTG.
Yes, because your labor itself is a stress. So you cannot call a CTG when taken during labor as a non-stress test. Correct? Because labor is stressful for the mother, baby, everything. So adnalada during delivery, when you do a CTG, you still call it CTG. Pregnancy la, before having any pain, anything, you do that, we call it NST. Otherwise, both are the same CTG which we take. Okay, ba? CTG machine la edukara trace da rendume. It doesn't make much of a difference between these two. Only thing, in labor you cannot call it non-stress test because labor is a stressful pattern. So once the patient is in labor, it becomes stressful. Okay, ba? So this you should remember. So how you should see a CTG is usually you have or cubes are be divided arukum. These each cubes will be 10 centimeters. Okay, and normal வந்து mark பண்ணிருக்கும். They would give you a color lining for that. Okay, so usually ஒரு green lining ல இருக்கும். Normal they will usually mark it between 120 to 160. இந்த line வந்து கொஞ்சம் different colored இருக்கும். மேல கீழ வேற கலர்ல இருக்கும். So you should know that இந்த patternல இருந்தா அது normal, மேல போனாலும் abnormal, கீழ போனாலும் abnormal அப்படின்னு தெரிஞ்சுக்கிறதுக்காக தான் இப்படி இருக்கும். and there will be a column where the patient will be having a machine to press the movements, and those movements will be seen here. Okay, so that is to press the movement. And there is something called as cardiotocogram. Tocona enna? Toco is uterine contractions. So keela, you will have a column to measure the uterine contractions. Okay, so adu vandu maximum uterine contractions maybe around 100 varaikum namak kuduthirupanga column. So 50, 100, 0 and the madri markings irukum. So this is how a normal CTG trace will be there. Maybe 10 centimeters abbe point irpo. Okay va. See basics purinjadan, then it will be very easy to interpret. So that when you go outside, when you work in a labor room, even when you become a postings and you go, you should know what a CTG means. Okay va. So once you get a trace like this, okay. So normally pathana, there will be something called as variability in the fetal heart rate. So fetal heart rate will not be like this. So you can either have beat to beat variability, or you will have a baseline, whatever you call it, baseline variability. Then you have accelerations. Acceleration. So inga vanda or baby or movements with this area, you can have accelerations of more than 15 beats and lasting for 15 seconds. So it lasts for 15 seconds and more than 15 beats. So this is called as accelerations. So at least you should have 2 accelerations in the period of 20 minutes. Okay, so 20 minutes trace ninga paakumbodhu, it should be at least, usually your CTG is set in a level at 1 centimeter per minute. Abdina 20 centimeters, that is 2 cubes pathada, you will have a 20 minutes trace. So it depends upon the speed which you set. Puriyarda. So if you set it as 2 centimeter per minute, abdin vechinena innu konjam unakku thappa varum. So you should know at what speed it's set. I'm sorry, I'll go it. I cannot undo it. Okay, so on the measurements la imagine panipon. So this is there. So you have something called as baseline variability. Then you have accelerations. So this at least 2 accelerations should be there, and there should be a baseline variability of more than 5 beats per minute. Abdina enna ipa idha vandu, if you're taking it as baseline, so in the mela keela move pannirukkiradhu mela ulladukku keela ulladukku ulla difference should at least be 5. Then only it is normal. So less baseline variability na ithnonu irukum. Appo konjam straight aidum. Indha madri unakku oru trace irunduchu abdina idu abnormal. Okay va? Ena baseline variability is less. So at least 5 beats minimum irukano. You should have 2 accelerations. Adutha decelerations irukka kudadu. So what are all the decelerations you have heard of?
Early deceleration, late deceleration, and variable deceleration.
Very good, doctor. Early, late, variable. So have you understand what these are? Okay.
Early deceleration,
so,
the heart rate coincides with the uterine contraction.
Okay. Late?
It will start after the uterine contraction. The deceleration will start after the uterine contraction and end after the end of uterine contraction.
This is your heart rate. Okay. So deceleration, so same thing. It goes down by 15 beats per minute, and it may last for 15 seconds usually. Okay, va. So this is there. Early na, see, usually you have a contraction. Okay. So peak of this contraction and this decelerations, they match each other like a mirror image. Okay, va. This is called as early decelerations. Okay. So with the contractions, the heart rate goes down. The moment your contractions are going down, the heart rate picks up. This is because of head compression during labor. Okay, va. Abdina enartham, it is like, baby is being pushed down, keela varudha, and with the uterine contractions, baby oda head is getting compressed. And idu vandu, if it happens early in labor, still it's significant. Nearing delivery, we take it, okay, the periya tissue kadiyadu abdin solittu eduthikalam. So early. Late is if a deceleration. So the next peak of contractions inga varudha, but in the decelerations vandu, it happens after the peak. So peak contraction la varla. Okay. But in the peak contractions pona paraga, you have a gap. in between the peak of the contraction and the nadir of the deceleration. அப்படி இருந்ததுன்னா that is called as late deceleration. ஓகேவா? between peakனா வந்து மேல இப்படி வந்து அது மேல சொன்னா peak, கீழே இப்படி வந்து இது சொன்னா இது nadir. அவ்வளவுதான். புரியுதா? you cannot say downward peak எல்லாம் வேர்டு கிடையாது. ஓகேவா? சோ அதனால வேர்ட்ஸ் கரெக்டா சொல்லணும். So it is like, you know, you have a time gap between the peak of the contraction and the nadir of the deceleration, then it is called as late. Variable அப்படின்னா என்னன்னா irrespective of the contractions. ஒரு சமயத்துல பாத்தீங்கன்னா it can still be early, இன்னொரு இதுல பார்த்தனா இங்க வரலாம், அதுக்கப்புறம் பார்த்தனா லேட்டாவும் வரலாம், அப்படி இப்படி மாத்தி மாத்தி வந்துருந்துச்சு அப்படின்னா we call it as variable deceleration. So it is not related to the uterine contraction. So variable deceleration is a sign of
cord compression.
Cord compression. Okay, so again it is an oligohydramnios. தண்ணி இல்ல, with uterine contraction your cord is getting compressed, na you can still get variable deceleration. So at least basics தெரிஞ்சா போதும். அதுக்கு மேல if you don't understand or if you don't know more, it is good enough. இது தெரிஞ்சா போதும். புரியுதா? So this sum of CTG, what to handle, இது தெரியணும். கண்டிப்பா one is your baseline variability இருக்கணும்னு தெரியணும். accelerations இல்லனா கூட பரவாயில்ல, decelerations-ல எந்த அளவுக்கு இருக்குன்றது importance தெரிஞ்சுக்கணும். So CTG, this level if you know, it is good enough. Okay va? How to interpret CTG அப்படின்றது. Okay. So one we said about biophysical profile pathoto, then we spoke about CTG, then already we told you what is amniotic fluid index, which level is told low, which is high, other pathoto. What other methods you know you can monitor? And basically kick count. So kick count pathoto. So where in Bishop score is for cervical changes.
Cervical, right.
So அடுத்து நீ வந்து cervix changes பார்க்கிறதுக்காக Bishop score. Okay, how else can you monitor the fetus? So these are the things which you are monitoring, or which is not very useful here for a post-dated pregnancy. What is your idea or your view about Dopplers? Doppler's ultrasound for the fetus. USGs.
Heart rate of the fetus.
IUGR, they are very, very important. Usually for prolonged or any acute hypoxic event, your Dopplers will not give you much information. Okay? Unless and until your baby is an IUGR, your Doppler per se for a prolonged pregnancy is of not much role. So that if you understand, good enough. Okay. So you have seen your baby is fine, you're monitoring. How often you want to monitor? It is 3 bi-weekly. Okay. Which means that once in 3 days. So every 3 days you call her, you do a modified biophysical profile. So as far as things are normal, you are going to allow her to program till 41 weeks. Then you are going to induce at 41 weeks. So now you are going to tell me what is Bishop score.
Bishop score, there are the components involved. Dilatation of the cervix is noted, ma'am.
Cervix dilatation. Okay, effacement.
And station of the head.
Station.
Cervical consistency and cervical position.
Okay, so position and consistency comes first also. So position, consistency, then your dilatation, effacement, station. And with all these things, you give a score. Okay, even if you can't remember the exact numbers, but at least you should know what is called as favorable, what is called as non-favorable. What is the cutoff?
It is more than 5 or 6 months. It's favorable.
Okay. So more than 6, usually we say it is favorable. Anything less than that, then we less than 5 or 4 or that number, then we consider it as non-favorable. Why should you know that? Sorry, cervix favorable, cervix non-favorable. What difference does it make? So non-favorable na enna panna pora, favorable na enna panna pora?
We can give intracervical gel to ripen the cervix, ma'am, in non-favorable condition.
Okay. So if your cervix is non-favorable, then you're going to need a ripening agent. Okay. Okay. So if it is favorable, then you want to augment labor.
Augment the labor.
Okay. Here you induce. So that is the difference, whether you want to induce labor or whether you want to augment. Augment na enna already ellame nalla irukku, but edo konjam kammiya irukku, so konjondada pottona seriya poidum. That is augmentation. Okay va? Induce na onnume illa, adu namma dhaan pottu seri panna porom, that is induce. So depending on the Bishop score, you are going to decide. Okay. So I am telling you a PV finding for your patient which says the Bishop score is poor. So now you tell me what are you going to do for the patient.
Ma'am,
Bishop
prostaglandin E2, cervical,
Prostaglandin
intracervical gel
E2.
membrane.
Okay. Gel. எவ்வளோ கொடுப்போம்? Dose?
Dinoprostone 0.5 mg, ma'am.
Excellent. 0.5 dinoprostone.
mg.
Okay. How
Repeated
often
for
can
3
you
times,
feed?
6 hours interval, ma'am.
So at 6-hourly interval, you can go up to 2 or 3 doses. Maximum you go up to 3. Okay, 2 is ideal, and up to 3 you can still go. Adukapra hopefully the patient becomes cervical, vandu konja changes nalla vandiruchu, favorable. Then what else can you do? Favorable aiduthu. Appo
We have to wait for 6 hours and then we can give oxytocin, ma'am.
okay, so you can augment labor with
Augment
oxytocin. So Synto vandu eppadi kudupinga? You give it through a
IV infusion, ma'am.
IV infusion. Very good. So at how much dilution? Any idea? How many units you put in? How many ml? 5 units if it's a primey.
Okay, ma'am.
Okay. If it is, some people even put up to 2.5 only, and then you put it in a 500 ml of RL,
For ringer
and
lactate.
then you give it in. Like you monitor the drops. We start at 8 drops.
8 drops per minute.
Maximum you go up to like 40 or 60 drops is what we go. Okay, 60 drops per minute, and then you can monitor that. Okay, so what are the mechanical methods of induction?
Membrane stripping, ma'am.
Very
Sweeping
good.
of the membrane.
Yes. Okay, please use the word sweeping. Okay, we are not stripping anything, so it sounds very odd. Many people don't like it, so it is sweeping. So what do we do in sweeping of membranes? You separate
The membrane.
the membrane from cervix and the lower uterine segment. So you should go do a PV, go gently, you can just separate the membranes. What is the drawback, or what all can happen in this? If you are not gentle enough, you can
Pain.
cause a rupture of membranes.
Rupture of membrane.
That is a wrong technique. Okay, this is not a usual complication. If you don't know to do sweeping, then only you will rupture of membranes. So the seniors or people who really know to do will never rupture membranes. So this is not a routine complication. If you are doing it in a wrong technique, then you do that. Infections, it has been found that there is no chance of infections. Okay, so this does not cause infections. So remember that this, once you separate the membrane from the cervix, okay, so naturally the prostaglandins are released.
Irregular
And
contraction
then this helps for contractions. Okay, so some people even start by around 38 to 40 weeks, so that they decrease the interval and they prevent even the post-prolonged pregnancies. Okay, so that is about sweeping, mechanical. Do you know any other mechanical method?
Foley's catheter, balloon catheter.
Yes. So what do you know about Foley's catheter, balloon catheter? Foley's. Usually we insert the Foley's. It can be either a 14 or a 16 size Foley's, 16 franc Foley's, whatever we have. We just insert that. Sorry. Okay. So that you insert into the cervical canal and just inside the internal os. It's not that fully we don't put. So you keep it at the level of internal os. So imagine this is your gravid uterus. Then you have cervix. So this is the external os. This is the internal os. So we insert the catheter here and then we fill the balloon. Okay.
Right.
So this is what is going to be there. We are going to fill the balloon with water. So depending on each person's thing, we fill it around 30 ml maximum. Usually it can be 20 or 40 usually. So what is the logic in using a Foley to put water inside the thing? So here the membrane which is in this region will get separated. Correct?
Okay.
So this is the membrane which is going to be there around the baby. So the moment you're going to insert the Foley, this membrane is separated, and after a little bit separation, this bulb is constantly going to be there. So the prostaglandins will start acting. So one advantage. The second one is once the cervix is dilated, the bulb automatically falls down. Okay. So it means up to the 3 centimeters, the cervix will be dilated. Okay, so the same technique, how you do mechanical stripping. Similarly, you put a Foley's bulb, then you inflate it so that the membranes get separated, prostaglandins getting released. How long can you have this Foley's? To a maximum of 24 hours. Then we remove that. Okay, otherwise the chance of infections are more. So these are the two mechanical methods, and these extra amniotic saline infusion and all, we don't use it at all. So don't tell all these things. And there is no role for any amnio infusion. If you see for meconium aspiration syndrome and meconium stain liquor, these are outdated. So you please need not tell all these things. This and all, they are not following, because it's been found in studies that these are all non-useful. Okay, so fine. So you have, you know about prostaglandin gel. So what other way the prostaglandins can be given? One is gel. What others? Have you
Oral tablet, ma'am.
I will.
oral tablet? Yes. So what is the oral tablet? Any idea?
So mesoprost.
Usually, yes, mesoprost. How much can you give? Dose?
800 micro.
Papa chittu poidum. Uyiroda papa ku kodukrom. This is not abortion. Papa chittu pogum. This will cause a lot of uterine contractions. Only for MTP you can cause 800 because you want to kill the baby or whatever it is. You just want the baby out. Here we want to deliver this baby alive. Okay. So if you are using oral, the maximum dose which you can give is 50 micrograms. Okay. And if you are using it vaginal, it can be only 25. This is the recommended doses. Otherwise, it will cause very strong uterine contractions and the baby will die. Okay. So it can be 50 mics. Either it can be given oral or sublingual. Okay. Or it can be 25 marks, which is vaginal. It can be again repeated in 4 to 6 hours interval. Okay, ma. So adanala find the difference between labor and abortions. It should be very clear. The other one which we all use is Primoprost also. Primoprost is not very available also. But at least if you know Mesoprost is good enough. Mifi also we don't use for a alive baby because it is found, some studies say that mifepristone can cause IUDs. Okay. So it is only for these IUDs and other things. It really works very well for MTPs, but not for these alive things. Okay, ma. So anything else vaginal, anything else you have heard of? Propes, anyone heard of Propes?
Yes, no, ma'am.
This is a Dinoprost vaginal pessaries. Okay, so this will be like a thin paper attached with a thread. Okay, the moment you keep it in the posterior fornix, we keep it in the vagina. And the moment we keep that, then this pessary swells and it releases the prostaglandin. Okay. The advantage is that in case if there is a hyperstimulation, that is the patient is like having too much of contractions, then you have a thread, you can just pull it out. So that is the advantage, and this can be left undisturbed for 24 hours. So you need not repeat PB again and again and give this. So this is also available, little expensive, maybe some 2,000, 3,000 rupees, but still it is there. So you should at least know that this is also one of the methods. Okay. So these are the methods, and oxytocin for augmentation you will know anyway. And I think that's all. Okay, so let us know something about shoulder dystocia. So you're pulled out this baby, and this baby is having shoulder dystocia. What is shoulder dystocia?
It's the arrest of the shoulder after the head is born, ma'am. The
For
extended
how many?
head to shoulder extension of 60
Time?
seconds, ma'am. 60 seconds.
Yes. If you take more than 1 minute or 60 seconds to deliver the shoulder after the delivery of the fetal head, okay, then we define it as shoulder dystocia. Okay. Or if there is any additional maneuvers required to deliver the fetal shoulders, then again it is shoulder dystocia. Okay. So what are all the risk factors for shoulder dystocia? Any big baby. So
Obesity,
tell me what are
macrosomia.
all. Yes. So
Gestational
mother is
diabetes.
obese. So
Gestational
mother,
diabetes
obese mother, GDM. Okay. Increased weight gain in pregnancy. So the mother is gaining some 30-40 kg. Definitely the baby is going to be 4 to 5 kgs. So all causes for macrosomias. So mother is obese or mother is having a GDM, increased weight gain, your prolonged pregnancy. Okay, all these are risk factors for this one, shoulder dystocia. Okay, so this patient, she's delivering, the head is delivered, shoulders have not delivered. So what are the things you can do?
Generous episiotomy can be given with
Okay.
traction.
Yes. So there is a mnemonic. First one will be whenever you get shoulder dystocia is call for help. So if you are alone, you have called the senior most obstetrician or senior midwife, anesthetist, everybody, whoever is there, because this is an emergency. Why this is an emergency? If you don't deliver the baby, say around within 4 or 5 minutes, the baby is going to die. Why should the baby die? You tell me. Why should it die? Shoulder dane. Why is the baby dying in shoulder dystocia? உள்ளதான் இருக்கு, ஜாலியா இருக்கு, ஏன் சாவுது? Why is the baby dying? Because the baby's chest cannot expand. Okay, it is there in the pelvic cavity, it is getting arrested. So baby will go in for asphyxia, lung expansion nadakadu. Okay, so the mother is not going to provide anything even more because the head is delivered, the placenta is not going to give anything more. So the baby cannot breathe. So definitely your baby will go in for asphyxia. So the first thing is call for help. I'm very happy you told about episiotomy. So if you have not given an episiotomy, you will give. If you have already given, then you will extend the episiotomy. Then what else?
Flex the legs.
Yes. So legs. Flex the legs. What is that maneuver called?
McRoberts maneuver.
McRoberts maneuver.
McRoberts. Okay. So flexing the leg, flexing the maternal leg and putting it over the mother's abdomen. Okay, so that will change the curvature of the sacrum so that the shoulder is delivered. Then it is the suprapubic pressure. Okay, so along with that you give a suprapubic pressure and that will help you. And then what else? Rotational maneuvers.
Shoulder.
Sorry?
Rotation of the shoulder.
Yes. So then you have certain things called as, like you need not know the other things. At least you should understand what it is. So the mother is here. You bring the mother to the edge of the table. So if she is like this, the table here, usually we all stand here and conduct delivery. So you bring the mother to the edge of the table. So that is the first thing which we do. And then you ask her to flex the leg on the tummy so that the sacral bone changes the curvature so that, like the anterior shoulder get dislodged and it can be delivered. The third one, what we all do is suprapubic pressure. So you feel for the fetus shoulders, and then you try to push the shoulder to the midline. So from the oblique diameter, you try to bring them to the anteroposterior diameter or push it to that, and so that it delivers down. So these are the things at least you should know. So if a case is GDM, definitely they'll ask you about shoulder dystocia. If your case is prolonged, definitely they'll ask you about that. Or if it is an obese woman, definitely they'll ask you about shoulder dystocia. So very, very important topic. You should remember these things. Okay. So is there anything else you want me to discuss? And I wanted to talk about growth scans. Okay. So what are all the things which we see in growth scans? When should a growth scan start? How many weeks?
Between 28 to 32 weeks, ma'am.
Yes, usually we decide between 28 to 32. If it is a low risk patient, even at 32 is good enough. If it is a high risk patient, then we start a little early. Okay. So what are all the things which we see in growth scan? Okay, biometry. What are all the parameters which we take it as biometry? Enna vapo?
Femoral length.
Femur length.
Abdominal
Okay.
circumference.
Abdominal circumference.
Head circumference.
Head circumference. Onnuda micham.
Biparietal diameter.
Biparietal diameter. So these are the 4 things which we use, and the computer will calculate our estimated fetal weight based on all these things. Okay. So a little about each thing you should know. So biparietal diameter, you take it in a plane where you know that arrow sign, or where your hypothalamus is seen. That is where you measure the biparietal diameter and the head circumference. So this is the BPD. And yeah, overall இப்ப நீங்க சுத்தி மெஷர் பண்ணோம்னா அது வந்து HC. And AC ஓட planeல you will have one side the spine, then there will be the stomach, and then you'll have the portal vein or the ductus venosus vein, ductus venosus, and then you can see the aorta and IVC here. So this is the plane where you see the abdominal circumference and your femur length. So in the madri hockey stick madri of femur length will be there. Sometimes you will see that epiphysis, we don't measure that. Inga varaikum we measure. So this is your femur length. So these are the biometric parameters. Kuncha about scan you're supposed to see. Okay, ba. And more important is the growth chart.
Okay.
So when you have growth chart, idhula vandu weeks irukum. So say around 16 la 40 weeks varaikum unga growth chart plot pannirpaanga. So minimum there will be 3 lines. Okay ba? So this is the 50th centile. So this is 5th, this is 95th. Okay ba? Some people will have even the 10th and then it will be 5th. Appdiyum irkalam. Okay. So why should you know that? And then the parameters growth chart important. இப்ப நம்ம 4 parameter பார்த்தோம். BPD, yes, IUGR க்கு okay. So BPD, HC, AC, FL, estimated fetal weight. இது எதுக்கெல்லாம் growth chart important?
Abdominal circumference and FL.
Very good.
Femoral length.
Abdominal circumference and estimated fetal weight. இது வச்சு தான் you can calculate about macrosomias and your IUGRs. FL குறையும், but FL வந்து எப்ப குறையும்னா when it is chronic, long term உள்ளது பண்ணாதான் FL will go down. So short term differences வந்து your AC ஏன்னா liver size குறையும், glycogen stores இருக்காது, glycogen store இல்லைன்னா liver சுருங்கிடும். Liver தான் abdomen ஓட major organ, so liver சுருங்கி போயிடுச்சுன்னா abdomen சுருங்கிடும். So that is the reason, and overall weight பாப்பாக்கு குறைஞ்சிடும். So if it is in the 50th centile, then you all know that the baby is doing well. And அந்த மாதிரி இல்லாம if your baby is falling, dropping, and it is less than 5th centile, then you know it is IUGR. Okay ba? So when you at least this தெரிஞ்சுக்கணும். அதே மாதிரி when your baby is growing behind இந்த சைஸ்ல வளர்ந்துட்டு இருக்கு அப்படின்னா then you know it is macrosomia. ரெண்டுமே important. Okay ba? So these are the things இது பண்ணும். So is there anything else you want me to tell or anything else you want to know?
About artificial rupture of membrane.
Very nice, doctor. I missed it. So tell me, what is ARM? Artificial rupture of membranes. Why should we do that? What are all the advantages of artificial rupture of membranes?
To induce labor, ma'am, if the cervix is ripe.
Yeah, if it is ripe, usually we take it to augment. Okay, so நல்லா இருக்கு அப்படின்னும் போது கொஞ்சம் augment பண்றதுக்கு ARM எடுப்போம். Early cervical changes அப்பயே வந்துட்டு நம்ம போய் ARM பண்ணி விட்டோம்னா it will definitely not progress very well. So அதனால to induce I will actually not suggest ARM. ஓகேவா? So அது வந்துட்டு one. What else?
Ma'am, it can lead to abruption of placenta, ma'am. Sudden drop of the, I mean,
In poly.
Okay, so எந்த மாதிரி patientல it can cause abruption?
In polyhydramnios, ma'am.
Excellent, doctor. So if you have lot of liquor, okay, and you do a sudden gush of fluid is left to go, ஒரு sudden gush அப்படியே போகுது கீழே, வாட்டரா லீக் ஆகுது, அப்பனாதான் abruption வரணும். Ideally, ARM causing abruption means wrong technique. Usually ARM does not cause. Okay, so அப்ப polyhydramniosல ARM பண்ணனும்னா எப்படி பண்ணனும்?
Controlled ARM.
control.
Excellent. How to control?
Keep your pad, I mean,
Keep your pad or your hand, you don't let down. அப்படியே அந்த மெம்பரேன் ரப்சர் ஆனோனே அப்படியே கையை எடுத்துட்டேன்னா அப்படியே மொத்தமா fluid ஃபுல்லா கஷ் ஆகி அப்படியே பிளாசண்டாவும் பிச்சிட்டு வந்துரும். ஓகேவா? So you keep your hand and you allow water to slowly come down. And head வந்துட்டு you will hold the head also so that head தாண்டி கார்டு வெளியில வந்துட கூடாது. In polyhydramnios, you do ARM in a wrong technique, there can be cord prolapse, there can be abruption. So இது ரெண்டும் வராம பண்றது more important. So one, ARM helps you to augment labor. Two, ARM when you do, you can see the color of labor, color of liquor.
Color of the liquor.
So if you know it is meconium stained fluid, then you know, then you can just go ahead and you will deliver by, depending on the cervical changes, whether you can give normal labor இல்லனா cesarean அப்படின்றது தெரிஞ்சுக்கலாம். So these are the advantage of ARM. One is to augment, second one to know the color of liquor. How do we do ARM? Anyone, any idea? So usually we have something called as Cocker's forceps. Okay, so in the forceps oda edge la வந்து பாத்தீங்கன்னா ஒரு teeth மாதிரி இருக்கும். Okay, so when you go, it will hold on to the either properly what you call it, உங்களோட membrane வந்து it will go and hold on, அதை பிடிச்சிட்டு அப்படியே எழுத்துனா கிழிஞ்சிடும் அந்த membranes. So that is, we use a Cockers. So there is something called as ARM hook also, where you have something, it is also available in plastic. இந்த மாதிரி ஒரு சின்ன hook மாதிரி இருக்கும். So நீங்க அழகா போய் இந்த மாதிரி ஒரு membrane bulging-ஆ இருக்கும்போது உள்ள போய் இதுக்குள்ள மாட்டி ஒரு கீ கிழிச்சிட்டீங்கன்னா அது வந்து வந்துரும். So that is your ARM hook. Some people even do it with the needle. ஒரு நீடில் ரெண்டு கைக்கு நடுவுல வச்சுண்டு, so 2 fingers of you, உங்களோட ரெண்டு ஹேண்டுக்கும் நடுவுல you keep this needle like this, you take it and then you go and rupture the membrane. But நிறைய டைம் இந்த நீடில் வச்சு நம்ம கையை குத்திக்குவோம். So that is the drawback. But in either ways you can do a ARM. Okay, ma. So fine. So anything else you want to ask?
When and all cesarean section is indicated.
Okay. So if your liquor is very less, say your AF5 is only 4, okay, so then it is very difficult. Still you can try, but most of the time it will not be there. Second, fetal distress. We all know the baby will be there in distress. So how all can you know the fetal distress in this prolonged pregnancy baby? It can be a bad CTG.
Okay.
You have decelerations, or if you have no variability, both are not very good. So when you have a bad CTG or when you have very low AF5, mainly we go with CTGs. Okay, so then you go for cesarean section. If it is a big baby, macrosomia, okay, mobile head, all these things are indications. And usually if it is associated comorbidities, usually you don't allow for prolonged pregnancy only. So if your patient is a diabetes mellitus, or if she's a hypertensive, or any other heart disease and all those things, you don't allow them to go for prolonged pregnancy. So in prolonged pregnancy, direct indications will be only if the baby is very big, or if the liquor is very less, or if there is a fetal distress. Then you do for cesarean section. Otherwise, you really can try normal deliveries. Okay. So are we done it, or is there anything else you want me to discuss?
Management for meconium aspiration syndrome.
Meconium stained liquor is what we manage in OBG. Okay. And aspiration is once the baby aspirates, we give it to the neonatologist, okay, or the pediatrician, and it is their thing. Usually they give a wash. Okay. So what they do is they take saline, they inject it. Usually they give a stomach wash. Okay. To remove the excess meconium. Okay. And ideally for meconium aspiration, you're not supposed to bag. So what they do is they intubate. They put a endotracheal tube. No, they put this one laryngoscope, and they do some suctioning, and then they intubate the baby. Most of the time, a very minimal aspiration, the babies will do well. Okay. Depending on whether the baby is having distress or not is depending on the management. If the baby is active, the baby is not needing any problem at all, then they don't do anything at all. They just give a stomach wash and they hand over the baby to the mother. Okay. So meconium aspiration comes when from the stomach, the meconium is got aspirated into the lungs. Okay. So that is when you get the meconium aspiration syndrome. Usually once it goes to the lung, you cannot do anything. You cannot take it back. So what we do is you intubate, and then you try to suction out whatever there in the level of your bronchus and trachea, but you cannot do anything in the lung. Okay. And then you give the baby oxygenation. You wait for the baby to recover on its own. Okay. So that is not in our hand. You put the baby in ventilator. You wait till the baby achieves spontaneous respiration. You wait for the meconium to get cleared and the baby recovers. So that is, that is a very long process. So our concept is to prevent the meconium aspiration. Once it goes to the lung, there is no way to get it back. Okay. So to prevent that comes the meconium stain liquor management. Okay. Previously, when we were used to be students, like, say some 20 years and all back, then at that time, what we do is we used to do amnio infusion, where we dilute the liquor, we give water, we put IV setter connected with NS, we put it inside, we do the ARM, we just push the tube into the uterus, and then we try to dilute the meconium so that, it doesn't cause complications. But over the years, it has been found that it is totally useless. Okay, so now we don't do all those things. So if you find a meconium stain liquor and the cervix is favorable, okay, and there is no fetal distress, that is your CTG is all right, okay, then you still continue with normal labor, normal delivery, you can still try. If it is not there, you know that the cervix is very unfavorable, or if your CTG is showing some decelerations or variability changes, then you go ahead, deliver by cesarean section. So these are the two things you should remember. If it is meconium stain, cervix is good, then you deliver. If you know that the delivery is not going to be immediately done, then you go ahead and do the cesarean section.
Okay.
Okay. So anything, doctor?
No.
Sorry, was it boring? I'm sorry, I didn't bring any pictures this time. Maybe next time I'll try to bring something for you. Chalo, so
Okay, ma'am.
shall we call it a day for today's class?
Yes, ma'am.
Yes, ma'am.
Okay, doctor. Okay, thank you
so much, ma'am.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
So next time we'll meet with another nice topic. So if there's anything, even with your theory, if you want, something which you don't understand, you can let me know so that I can prepare and get some pictures for you and show that. So if there's anything you discuss with all your